time no see. Is there a call coming in?
It's called potential spam, so I don't think I'm going to answer it.
Anybody have another class after this one?
Mine's at 6 o'clock tonight, so I got a while, but yeah.
Is it the first aid one?
Yeah, first responders one.
Is that the 3-hour one?
Yep.
Well, not quite all of us. We've got 19 in this class, so.
Is it on campus?
Yeah, I think so. I think it's here.
It's in this room.
Oh, okay.
At least that's where it was last semester.
Is it an EMAR? Huh? Is it an EMAR class? Because I have to do continuing education, I'll just like sometime this year. I might see if I can
Well, at least it's over with one part.
Yeah, just one day a week.
Yeah.
And most of the time it never went the full 3 until there's only a certain few times it actually went.
Good to hear.
Welcome. Oh, Brian. Welcome, Lucas. How are you? All right, well, it is time. Okay, so last time we began talking about some introductory terms, directional terminology. What's the opposite of medial? Lateral, proximal,
Distal,
anterior, inferior.
superior.
Good. Okay. And then what are the three cardinal planes of motion? Sagittal. How would you describe sagittal plane motion?
Front and back.
Yeah, forwards and backwards, front and back. Sagittal plane. What else?
Frontal.
Frontal plane. How would you describe frontal plane motion?
Side to side.
Side to side. And then what's the last one?
Transverse.
Yeah. And how would you describe that?
Rotation.
Yeah, rotation. Now, what's the extra plane that kind of is more like a combination of planes? Yeah, diagonal. Okay, so what's the relationship between a plane and its associated axis? Yeah, 90 degrees. So think of the tires rotating about an axle. Body segments rotate about an imaginary axis through a given plane of motion. So we've got some stuff to cover on bones today. Then we've got joint types, and then we have class activities. So do you have any questions about Chapter 1 material so far? Okay, all right, so let's jump right in. So we talked about long bones, so the next would be flat bones. So scapula, as well as the sternum, as well as the ribs. So these bones are well designed for muscle attachment. So there's a broad area through which muscles attach via their associated tendons. The scapula is the only connection, or one of the few connections, there's actually two, but it's the major connection to the axial skeleton for the upper extremity. So the scapula glides on the posterior side of the rib cage. It's called the scapulothoracic joint. So whereas many of the other joints we talk about in the body will have a joint cavity and and structurally classified as synovial, freely movable, diarthrodial type joints. The scapulothoracic joint is unique in that it does not have a joint capsule. So it's one of the exceptions where we have a diarthrodial, highly movable joint, but no joint capsule, like the shoulder or elbow or some of the other diarthrodial joints. So most of the movement of the scapula takes place at the scapulothoracic joint. So again, the articulation between the anterior surface, this is the posterior surface, so the anterior surface of the scapula and the rib cage. So if you think about all the different movements you can do with the scapula, so we can elevate our shoulders like this, that's really not an action that takes place at the shoulder joint. That's simply the scapulothoracic joint that enables the scapula to glide up and down. Okay, so the scapula can also glide laterally and medially as well, and it can upwardly rotate and downwardly rotate. So commonly, shoulder joint problems are a symptom of scapulothoracic dysfunction. So in order for the shoulder joint to function optimally, we have to have optimal movement of the scapula. So we keep coming back to this concept in this class where in order for one joint to do its job, there's another joint that has to do its job. So we can get symptoms, shoulder impingement or shoulder pain and so on, if we don't have adequate movement of the scapula. So as an example, you see this exercise where we have, it's a rowing type exercise, where we have extension of the shoulder joint. Well, in order for the shoulder joint to extend, we have to have what we call retraction of the scapula. So retraction of the scapula. So we're bringing in the scapula on both sides towards the spine. So sometimes rather than scapular retraction, we call that scapular adduction. Adduction, ADD. So adding in towards the spine. So in chapter 5, we will stress the importance of these complementary actions between the scapula and the shoulder joint. So if you know what the shoulder joint is doing, you know that the scapula has to be doing another action for the shoulder joint to function properly. Okay, so irregular bones. So these are bones that have odd shapes, very specialized functions. So an example here would be the sphenoid bone. So that's one of the 8 cranial bones. The maxilla, that you don't see pictured there, is one of the 14 facial bones. And then the vertebrae. So we have 31 vertebrae, 24 of which are movable. And so there's lots of different processes and facets that allow for connection with other bones or attachment of muscles. So the next category is sesamoid bones. So the largest sesamoid bone in the body is the patella. That's a good test question. The largest sesamoid bone is patella. So the function of these sesamoid bones is to give muscles greater mechanical advantage. So leverage is the key function of sesamoid bones. So sesamoid bones stretch the tendons of their associated muscles, so we are able to apply greater torque. So I'm sure all of you have heard that term, torque. If you take biomechanics in the spring, you'll talk about torque constantly. So torque depends on 2 things, force, but also on the distance from where the force is applied to the axis. And so that distance is called the moment arm. So let me give you an example here. So here's a view of the patella, anterior and posterior view, as well as this sesamoid bone right under the great toe in the flexor hallucis longus muscle. You can see two sesamoid bones there. So here's a view of the left knee, the medial side of the left knee. And we see the patella. Okay, the patella articulates with the femur to form the patellofemoral joint. And so if you can imagine the patellar tendon from the quadriceps coming across here, kind of like tendons can be likened to cables. And so you have this knee joint with its axis, so the A stands for the axis. And so this patella is embedded within the patellar tendon. And so what is the function of the quadriceps at the knee joint? What does the quadriceps do exactly at the knee joint? It extends. Yeah, that's right. So in order for the quadriceps to do its job, extending the knee joint, it's going to get a lot more leverage from this patella because the patella stretches the quadriceps tendon just a little bit. You remember what the two components of torque are? We have the force, which in this case comes from the quadriceps. What was the other component? Yeah, the distance from where the force is applied to the axis. So in this case, the distance would be right here, where the quadriceps tendon comes through, eventually attaching down here to the tibial tuberosity. The distance we refer to is from the axis to where that force is being applied. So it's this distance right here. So that's the other part of torque. If we have a greater moment arm or greater distance between where the force is applied and the axis, the quadriceps are able to produce greater torque. So that's the whole thing with sesamoid bones is they improve our leverage. Okay, so typical bony features, we have a diaphyses. Okay, so that's the middle part. And a lot of these typical bone features we see in long bones. Okay, so like the femur, tibia, fibula, humerus, radius, ulna, these are all examples. So the long cylindrical shaft, and then on the very ends, we have the epiphyses. So we have a proximal epiphysis or epiphyses here and down here. Okay, now I want you to look closely at that picture. On the outside, we have a very dense type of bone. So it's hard, dense, very compact. We call that cortical bone. So that's where we have the highest mineral content in bone, is in this cortical bone that makes up the cortex. So when you think of cortex, you think of the outside, the surrounding wall of a bone. That's the cortex. So very high in mineral content. It's also very strong in resisting compression. So what do you think of when you think of compression? What type of force are we referring to with compression? Okay, that's good. Okay, so she says straight down. Okay, that's good because gravity compresses our bodies. Okay, so we think of pushing together, right? Okay, so bones are very strong in resisting compression due to this outer layer of cortical bones. You can see it forms the walls of the diaphyses. Okay, so the periosteum is this fibrous connective tissue cover on the outside of the bone. So in the body, you'll see words that have this peri as the prefix. So anytime you see that word peri, you know it refers to this outside covering. So pericardium, how many have heard that? Pericardium refers to the sac that holds the heart. So periosteum is this fibrous membrane that covers the outsides of bones. Cartilage also has an outside, it's called the perichondrium in that case. So with physical activity, what we see is not only adaptations in muscles, but we also see adaptations in connective tissue. So why does that make sense where if you're involved in lots of activity and your muscles are getting larger and stronger, why does it make sense that your tendons and also bones and also the fibrous covering of bones would also have to get stronger? And it turns out that these connective tissues are strengthened prior to when we notice changes in muscle strength. So why would that be a logical sequence of events to have the connective tissues get stronger before the muscles?
Because when the muscle gets stronger, it's gonna create more force. If the connective tissue hasn't adapted, it's gonna cause injuries.
Yep. So it's an injury preservation mechanism. So we have to have the stronger connective tissue to support higher forces that muscles produce. So what we tend to see is tendons get thicker. And remember, tendons attach to bone. So what happens is the periosteum, which is where tendons attach, will also actually grow over the tendon. So the attachment point of a muscle is actually anchored with more stability after training. So that's very important. So you've got these bigger muscles that are these force-producing motors of the body, and in some cases can actually pull a tendon right off the bone, right off the attachment point. So we call that an avulsion fracture. So the logical order of events would be you have to have a stronger attachment. So the periosteum itself grows over the tendon. So you have a stronger attachment to withstand more force. And then the endosteum, that's on the inside. So if you notice here, there's this cavity called the medullary cavity or medullary canal. And so the endosteum lines the inside of the cortex along the medullary cavity. So something unique about the medullary cavity is this is where we have the yellow marrow. Do you remember from the little article read we had last week, what percentage of our total body fat is contained in the yellow marrow? Do you remember? It was about 10%. So if you took all the fat tissue in your body, 10% of it would be in this medullary cavity. It's very important. When you were born, all the marrow in your body was red. And so as you developed and now you're in adulthood, about half of it has converted into yellow marrow. That's a reservoir for fat storage. So the function of the red marrow, and the red marrow is located within the epiphyses. You see how this bone looks in the epiphyses underneath the cortex? It's kind of got a spongy or porous appearance. That's where the red marrow is located. So your body is constantly producing and recycling red blood cells. So if you have a traumatic injury where maybe you have some blood loss, the yellow marrow, it's amazing. The yellow marrow converts back to red marrow to help preserve your blood volume. So the yellow marrow can actually convert back to red and help contribute blood cells. So your body is amazing at keeping you alive with all the different stressors that can happen. Okay, so here's just another picture. It's a little bit better picture, but remember the red marrow is where we have stem cells that produce all the different types of cells associated with the blood. So not just red blood cells, but also white blood cells, all the different types of white blood cells, and also platelets that are important for blood clotting. So notice the compact or cortical bone here on the outside, and then you get in here where the red marrow is at, has more porous type appearance. So sometimes we call that spongy bone. Spongy bone. So there's a couple of other names that you might see in your textbook, trabecular or cancellous bone. I just expect you to remember one. Doesn't matter which one. You choose which one. spongy, trabecular, cancellous, whichever one's easiest for you to remember. Okay, so the epiphyses, that's where we have these cartilage plates that continue to produce these cartilage-type cells that gradually undergo mineralization. So eventually we have mineralization of the epiphyseal plates when we reach our full stature. So we can see remnants of these epiphyseal plates after undergoing ossification. Right. Another unique feature is bones have hyaline or articular cartilage over the ends. Cartilage is an amazing tissue. It acts as a shock absorber. So with joint unloading, like you are now, you're sitting in a chair, your joints are unloaded, the cartilage at the ends of long bones is absorbing water, or I should say joint fluid, kind of like a sponge. So in situations where your body is unloaded, we have this absorption of water and expansion of the cartilage. And then as you stand up in a weight-bearing position, all of that joint fluid is then pushed out. So cartilage acts as a shock absorber by absorbing water and then pushing water out as we bear the weight of our body. Cartilage also helps to minimize joint friction. Cartilage has a very poor blood supply, so we say that it is avascular. Avascular, poor blood supply. So if it has a poor blood supply, how well does it regenerate? I think not real well. So we have to. Physical activity is important though, because what happens with cartilage? You think with weight-bearing exercise? Within limits, it gets thicker. Okay, so cartilage, weight-bearing activity is healthy for cartilage, but it's possible to overdo it with any type of weight-bearing activity to where the cartilage is not able to regenerate or keep up with that stress, and so we can wear down over time. So wearing down of cartilage over time is associated with arthritis and joint pain and those things, but physical activity is really good within certain limits to help build up and preserve cartilage. So how is it that bones grow? Bones can increase in width throughout our lives. Okay, and so the way that happens is the periosteum has two layers. So it has an internal layer. Okay, this is called the cellular layer. So the periosteum has these active bone-producing cells. Do you remember from another class what the bone-producing cells are called? Yes, osteoblasts. So this is where the osteoblasts are located. So you can see this layering of bone, layer upon layer, kind of like the rings of a tree. So bones are increasing in width. And so these osteoblasts are producing new bone tissue. So what is bone tissue made of? It's made of mineralized collagen. So these osteoblasts produce collagen that undergoes mineralization, and that's what gives bone its characteristic hardened or rigid structure. And then on the outside, that's where you have the fibrous layer. That's where tendons have their attachment point. So your bone mass is really a balance between the activity of osteoblasts and osteoclasts. Okay, so in order to have an increase in bone mass through weight-bearing activity, okay, so we have to have a sufficient stimulus for our bones to make that change, because we know with inactivity, our bone mass tends to drop. With space travel, astronauts tend to have a lower bone mass when they return to Earth. Okay, with extended bed rest, bone mass tends to drop. So weight-bearing activity is really important to preserve bone mass, but to increase bone mass, we have to have elevated activity of osteoblasts relative to osteoclasts. So sometimes in older age, people can develop what's called osteoporosis. In such cases, we have a greater activity of osteoclasts and lesser activity of osteoblasts. So there's an imbalance there. So we're releasing calcium into the bloodstream and our bones are breaking down and becoming more brittle. So weight-bearing activity is so important because that tends to stimulate the osteoblasts. Now, similar to muscle tissue and how muscle tissue remodels, bone tissue is the same way. Every bone cell in your body is replaced every 7 years. So bone tissue is constantly recycled. So to recycle something, don't we have to tear down the old? Yeah, so osteoclasts, they're useful because they tear down the old, worn out bone tissue and get it ready so that the new bone tissue can be put into place. So bone remodeling is a lot like muscle remodeling. We tear down the old or the damaged tissue, and then we have cells that promote buildup of new tissue. So you're at a point in your life right now, young adulthood, where you're establishing your peak bone density. Very important. You're at a time in your life where your skeleton is very responsive to osteoblast activity. So right now in your life, you're setting yourself up well for successful aging. So your bone density is really high going into later decades, your 30s, your 40s, your 50s, and so on, where it becomes much more difficult to get that activity of those osteoblasts. So as we get into middle age, it becomes more a question of maintenance versus trying to build even more. So right now your bodies are so responsive from a muscular standpoint, from a neural standpoint, from a skeletal standpoint. Right now is the time to set yourself up well for decades to come. Okay, so what are bones composed of? Well, minerals. Okay, so calcium phosphate, calcium carbonate, okay, 60 to 70% of bone weight. But bone also has a lot of water in it. Okay, water is needed for all those chemical reactions such as collagen production that goes into producing new bone tissue. Collagen is the most common protein in the body. There are 19 different types of collagen. We find collagen in different forms in many different tissues throughout the body. And so collagen in the context of bone provides flexibility. Do you remember from the reading last week how much the tibia compresses with each foot contact when running? Wasn't very much. It was like a millimeter. So bones are not these brittle, dry structures that you see. You know, you're out hiking and you see what's left of an elk or something that passed away. You see the skeleton. Bones in our bodies are very dynamic. They're very vascular. They're always remodeling themselves. So collagen gives bone flexibility. So bones are able to bend and resist this tensile force. So we said compression was pushing together. Then what's tension or tensile force? What are we talking about there? Yeah, exactly the opposite, pulling apart. So because of bone's mineral content, it's very strong in resisting compression, but because of its collagen, it's very strong in resisting tension. Okay, so very important. This will be an exam question. Wolff's Law. What is Wolff's Law? Well, basically says that bones will adapt according to the stress placed upon them. So adaptations in bone are site-specific. So if we're doing a lot of squats, then the neck of the femur tends to get thicker. If we're doing a lot of presses, the bones in our wrist get thicker. So wherever we apply the stress is exactly where we have this remodeling taking place. So the bones become more dense over time. So here's all the different types of loads. We talked about compression and tension, which are probably the most common. Less common, we have this shear type force, which is more like a parallel force. So we get a lot of shear as bones slide over each other in joint actions. We'll talk more about that. Torsion. So torsion is kind of like this twisting type of force, and then of course bending. So the two most common would be compression and tension. Tension is probably the most common because of gravity. So in a weight-bearing position, what are we really working against to keep our bodies up? Gravity. Gravity is always applied to our bodies, and so we have to have our muscles and associated bones that resist that downward gravitational compression. So the femur is the largest bone and has a tremendous capacity to withstand compression. So over a ton of compression before fracturing. So this is a femur you can see undergoing a load test. So pound for pound, bone is stronger than concrete. It's also lighter. So it's just an amazing type of material that we have to support our muscles. Fun fact from a study looking at elite tennis players. So the arm that holds the racket was, on average, 40% bigger than the opposite. That's amazing to me, and in some cases as much as 63%. So, perfect example of Wolff's Law, where if the adaptation in bone is exactly specific to what we're doing as part of activities. Okay, so Wolff's Law applies to bone. Davis Law applies to soft tissue. So muscles, tendons, ligaments. Okay, especially muscles. Okay, so soft tissue, when placed under tension, think about, okay, so static stretching. Okay, so muscles and their associated tendons are placed under tension, right? So when you place a muscle and tendon under tension, don't you feel a little bit of discomfort? Okay, so that's the recommendation with static stretching, right? We take a joint and its associated muscle to the point of, to quote the ACSM guidebook, is to mild discomfort. Because that's when we know that we're getting just a little bit of tension. We're overloading that musculotendinous unit. And so just like anything else, what's the body going to do? Well, it's going to increase the length of that muscle and tendon just a little bit. And why does it do that? Because the next time we stretch that far, it's going to feel easier. So it's not that the stretch is changed, it's the tissues that are being stretched have increased their ability to do that range of motion. So conversely, if a muscle is tight or overactivated, it will tend to be in that state over time. So this gets into a good discussion on muscle balance. So after we finish up the functional movement screen, we're going to have a week where we talk about correcting compensations. So how do we create the proper balance? If we see a movement compensation, what do we need to do to correct it so we get the ideal movement pattern? Okay, so joints, functional classifications. So there are three, going from immovable, so synarthrodial, to slightly movable, amphiarthrodial, to highly movable. So that's diarthrodial. So we study the diarthrodial mostly through this class. Because kinesiology, right, is the study of movement. So this is what we're interested in, less so with the other functional classifications. So, but we take a minute and we talk about them. So synarthrodial, immovable, at least we hope so. So sutures of the skull. So I have 4 kids and 3 daughters, 1 son, and my son, when he was about 6 months old, he had a misshaped head. Okay. He was also an early walker, which tended to work out pretty well because I'm going to tell you, he had to have a helmet. So he had to have a helmet for about 9 months to get his head nice, and so now he's 10 and he's got this nicely shaped head. But he was also an early walker, and he had this little crash helmet, so he would. It worked out perfectly, and he doesn't even remember it, but we still have it somewhere in storage, just because. So the sutures of the skull. Why is it that they suggest that he wear a helmet at 6 months old? Why not wait? Yeah, so these sutures haven't completely mineralized. They haven't completely sealed off and hardened. So there's that window of opportunity within the first 18 months of life where it's still malleable. And so thank goodness, because now he's doesn't have to be self-conscious. He's got a nicely shaped head. So gum focis are the sockets that hold your teeth. That's another example. So amphiarthrodial, slightly movable. Okay, slightly movable. So syndesmoses, symphyses, and synchondroses. So let's take an example of each of these. Syndesmoses. So that's going to be this fibrous sheet between the bones of the forearm, okay, so the radius and ulna, okay, the fibrous sheet between those bones, or between the bones of the lower leg. So between the tibia and the fibula. So you can see these bones right here, the tibia and the fibula. This would be an example of a left tibia and a left fibula. So the fibula is always on the lateral. It's on the lateral side, tibia's on the medial side. So you have this ligamentous sheet that provides some stability there. So it's important that we have a little bit of movement there because as you dorsiflex, okay, so dorsiflexion is bringing the foot towards your leg, okay, there has to be a little bit of opening right here between those bones. So as we move the foot into dorsiflexion, we're moving the toe up, we get just a tiny bit of separation here between the tibia and the fibula. So we call that the inferior tibiofibular joint. So that makes sense. So joints are sometimes named according to the bones that are connected. So tibiofibular joint makes sense. Okay, symphyses. So this is a joint that's separated by a disc, a cartilaginous disc. So the pelvic bones are joined anteriorly by the symphysis pubis. So you have this disc. And so you can see here the birth canal. And so during pregnancy, there's hormones, especially relaxin is a hormone that's released. And so you get some laxity in these joints, especially the symphysis pubis. So there has to be that opening in the birth canal because that allows the baby to slip through. So another example would be the connections between the ribs and the sternum. So those are sometimes important because during exercise we're breathing with greater frequency and depth, so our rib cage opens up a little bit more to allow more air into the lungs. The other example of the symphyses would be the discs between the vertebral bodies. So the intervertebral discs, and those are help to absorb compression as well. Overnight, when you're in that unloaded position, those discs can absorb water. So how many of you knew that when you first wake up in the morning, you're just a little bit taller because these discs can absorb water overnight, so they expand. Okay, so I did talk about the ribs, but the rib connection is actually a synchondroses type of joint. So you have symphyses, syndesmoses, and synchondroses. So it may take a little bit of time to kind of get all the functional classifications. Thinking about the immovable synarthroses, gonphoses, slightly movable, syndesmoses, symphyses, and synchondroses. It's the cartilage connection between the ribs and sternum. So these are called the costochondral joints. Okay, so now we're at where we really want to be, the freely movable joints. So most diarthrodial joints are also synovial. So what that means is most diarthrodial joints have a joint capsule. So this isn't representative of any one joint in particular. It's just showing that you have bones, long bones that have this layer of cartilage, and then you have this joint capsule on the outside. So this joint capsule encapsulates these bones that form the joint. This synovial cavity is lined with a special tissue called a synovium. That's in white here. The synovium secretes the synovial fluid. So that's how we're able to provide oxygen and glucose to the cartilage, is because of this synovium. So remember, as we unload, the cartilage absorbs that fluid, and then as we load our body, that fluid is then squeezed out. So we provide that nourishment to the cartilage that way. So this describes that process here. Okay, so some diarthrodial joints have extra ligaments inside the joint capsule. So the cruciate ligaments, the anterior and posterior cruciate ligaments in the knee joint are a good example, as well as fibrocartilage discs. So the knee joint is probably the most complex joint in the body. So in addition to the capsule, it has these ligaments inside the capsule as well as these fibrocartilage discs. So the medial and lateral meniscus that increase knee joint stability. Some other examples, the glenoid labrum at the shoulder joint increases stability of the shoulder, as well as the acetabular labrum at the hip. Okay, so different diarthrodial joints have different amounts of movement capability. So some diarthrodial joints are able to move through one plane of motion. Okay, so a good example would be the elbow joint. What does the elbow joint do? from the anatomical position, or really any position, the elbow joint has one plane of motion, 1 degree of freedom. It flexes and it extends. It can only do one plane of motion no matter where we are, okay? Just does that one thing. So the elbow would be considered a uniplanar joint. Uniplanar joint. Okay, some diarthrodial joints are able to move through 2. Okay, so take a look at your knuckle joints. These are knuckle joints, or formal term is metacarpophalangeal joints. Okay, so we don't talk about the thumb because the thumb is unique, but the other 4 metacarpophalangeal joints, what can they do? I can do this, and I can do this. So that's one plane. What else can I do? I can do this, and I can do that. So that's 2. Okay, so that's a good example of a, not uniplanar, but what do we say when 2? Yeah, biplanar. So another example of a biplanar joint, okay, your wrist. Okay, so the wrist, the formal term is the radiocarpal joint. So your wrist, what can you do with your wrist? I can flex it. And I can extend it, so that's one plane. What else can I do with my wrist? Especially if you're a baseball player. You can do this. Okay, I can move it side to side, and I can do that. Okay, so that's 2. So the wrist is another example of a biplanar joint. So motion in 3 planes. Can you give me obvious examples of a joint that is very highly movable? Actually, good. So shoulder. So shoulder, you can do just about anything. Okay, so all 3 planes, so sagittal, frontal, transverse. Okay, so, which brings up a very interesting point. The more freedom of movement you have, what is the relationship with frequency of injury, you think?
Goes on.
Yeah, so more mobility, as in the shoulder, means less stability. So there tends to be an inverse relationship between mobility of a joint and stability of a joint. So because the shoulder is so highly mobile, and we get athletes that use their shoulder a lot, it's going to be a very high risk for injury. So we do things to help bolster, to try and help bolster the muscular stability of that joint, so it helps support all of that mobility. So athletes that throw a lot or spike a lot or serve a lot, they're going to have a lot of stress on that area. So we have to find ways of improving stability.
Is 3 planes multiplanar?
Yeah, multiplanar. So I've seen triplanar, but multiplanar I think is better because sometimes you got diagonal plane in there as well, like with the hip and shoulder. So, okay, so the 6 types of diarthrodial joints. Notice that's yellow, so that's important. So later today we're going to do an activity where practice these different classifications in the body. So first one, arthrodial. And we're going to go through these progressively, and then we're going to do a small group activity to reinforce concepts. So I'm going to go through each of these one by one. So let's start with arthrodial. So the first of 6 classifications. So diarthrodial, you have 6 different types of diarthrodial, freely movable joints. Arthrodial is number 1. Lots of examples here. Arthrodial joints are multiplanar to start with. Arthrodial joints are multiplanar. Some examples include the intercarpal joints. Inter means between, so these joints between the carpal bones. Another example would be the patellofemoral joint. So remember we mentioned that a little bit earlier. So the articulation between the patella and the femur is another example of an arthrodial type joint. Another example is the sternoclavicular joint. So I want you to just kind of follow your clavicle from the lateral end, just kind of follow it all the way down to where it connects with the sternum. Okay, that's called the sternoclavicular joint. That's another example of an arthrodial, sometimes we call that a gliding type joint. So you might be asking, well, which one should I remember? This one or this one is fine. Whatever one you can remember works best for you is fine. Okay, so we have gliding type movement taking place. I want you to keep your fingers there on your sternoclavicular joint, and I want you to elevate your shoulder and then depress your shoulder. Elevate and depress. And you can feel that rotation taking place in that joint. So it's just a little bit of a gliding action between the medial end of the clavicle and then the sternal notch on the manubrium of the sternum. Okay, so arthrodial is number 1. Ginglymus is number 2. Ginglymus is a uniplanar. What was arthrodial? Multiplanar. Ginglymus is uniplanar. So that means 1. So this is sometimes called a hinge joint. If we draw a mechanical model of the elbow, it kind of looks like a hinge. So these joints, they flex and they extend. So the elbow is a classic example of a pure hinge joint. The knee is not a perfect example. So if you put one fist on top of the other one, so the knee joint does flex and it does extend, but the knee joint is different than the elbow joint. So as you flex and extend your knee joint, you have some rotation. You have some rotation as it flexes, rotation as it extends. So it's not a perfect hinge joint. The ankle joint is a good example. It's like the elbow. It's more of a pure hinge type joint. There's a lot of joints going on down there with the ankle and the foot region. Don't get motion at the ankle joint confused with other joints that allow you to turn your foot in and out. So turning your foot in and turning your foot out, it's in the ankle region, but it's different joints versus the true ankle joint, which is just, what do we call this? Raising up on the toes? Maybe plantar flexion, and then bringing the foot in, again from earlier today, dorsal flexion. Okay, so 4th category. So this is trochoid. Trochoid is sometimes called pivot, a pivot type joint. Pivot type joints are uniaxial. So one plane. So what plane would this be? If I was sitting or standing here in the anatomical position and I have my hands palms up, which is, what do we call that position? Yeah, yes. Specifically, if the palms are up, what do I call that? Supinated. Okay, so then if I turn my palms over, yeah, they're now pronated. So what plane would this action be in? Yes, it would be transverse. So I'm rotating around. That would be a transverse plane action from the anatomical position. So one plane, transverse plane. So the example here that you see here, the proximal radio-ulnar joint. So it's not the same as the elbow. The elbow is the humerus and the ulna. That's flexion, extension. The radial ulnar joint is just below here, between the radial notch on the ulna and the head of the radius. So this would be a right arm looking at this way, and so we can pivot like this. So another example that I didn't list here would be the atlantoaxial joint. Atlantoaxial joint. So that's the second joint in your spine, and that allows you to rotate your head. So that would be another pivot type joint, the atlantoaxial joint. It's another example. Okay, so the fifth category, condyloid. So the condyloid is easy to remember because all of the condyloid joints have two planes of motion. So they're all biplanar. So what were the two examples we went over that were biplanar? The knuckles, right? Metacarpal phalangeal joints, sometimes called MCP joints, and then wrist, the radiocarpal joint or the wrist are examples of condyloid, two planes. Okay, anarthrodial. Okay, this is also called ball and socket. So take a look at your shoulder, or think about your shoulder. Think about your hip. Okay, at the shoulder, you've got the femoral head that articulates with the glenoid fossa. That's the socket. At the hip, you've got the femoral head that articulates with, what's the socket for the hip joint called? Yeah, acetabulum. Okay, classic examples of ball and socket joints. So lots of movements. Look at all of them on here that we've mentioned at least once. Flexion, extension. Anatomical position. What plane does flexion, extension take place in? Yep, sagittal. Okay. Abduction, adduction. Okay, abduction. Adduction is?
Frontal.
Yes, frontal. Diagonal abduction. That's kind of an interesting one. So how many of you have ever used a lawnmower with a pull start? Okay, so diagonal abduction, you're here, and then what do? The first time you mow the lawn in the spring, you hope it starts, right? So you're here. Okay, so you're going from a low position to a high position in the diagonal plane. So why is it abduction? Because you're going from more the midline of the body, you're going away from the midline of the body. Whereas diagonal adduction, we think about Corey when he throws. Okay, so any athlete that throws, they're going to come from high, and then where do they end up? They're coming down across the body, right? Okay, so they're coming more into the body, so that would be diagonal adduction. Okay. Rotation, okay, we can rotate, shoulder and hip can rotate. Circumduction, how many have heard of this one? Circumduction, okay, so you're inscribing a circle with the tips of your fingers like this. That's circumduction. Horizontal abduction and horizontal adduction. Okay, so these are special movements, usually describing the shoulder. So everybody put your arms out like this. Okay, so we're going to go from here, we're going to go back like this. Okay, so that's horizontal. Sorry, we're too close. Horizontal abduction. So coming from the middle, away from the body like this, okay, horizontal abduction. So what would the opposite of that be then? Going from here into the body would be horizontal adduction. You're adding to the body in the middle. So are there any questions at this point? Can we go just a little bit further and then we'll get to our activity? Okay. So the very last one out of the 6, okay, is the sellar or saddle joint. This is also really easy because there's only one example in the whole body. So if you go right down here, right here, it's the base of the first metacarpal and the trapezium. So the trapezium is one of your carpal bones. So this joint, the first, is formally called the first carpo-metacarpal joint. The first carpo-metacarpal joint. It allows for this movement of the thumb across the palm. So going from out here to where we're going across the palm, that's called opposition. Opposition. And then going from this position back out is called reposition. So really easy to remember, just that one carpo-metacarpal joint is the only example of a sellar or saddle joint that we have in the whole body. Okay, so we talked about the inverse relationship between stability and mobility. That's what we have here. So as mobility goes up, stability goes down. As stability goes up, mobility goes down, etc. Okay, so how do we measure movement? We have tools that we use to do that, cameras, and so on. But we have very simple tools as well, like a goniometer. And so we'll be doing some measurements in lab with goniometers. And in the 106 lab, you probably also did some things with goniometers. So very simple, you place the axis of the goniometer and the non-movable part of the goniometer against the segment of the body that isn't moving, and then you rotate the movable arm of the goniometer with the joint, and then you get this angle right here. So you can read the angle on this dial in degrees. So that's useful as we go in different stages of rehab to look at how range of motion changes with time, with recovery, and so on. Okay, so down to the end here, and then we'll get to our activity. So abduction. So I like this word lateral. So we're going away. So last year, I still remember, a student asked a question, well, okay, so I'm going away, but then once I cross 90 degrees, what am I doing? Coming back in. Okay, so it's one of those things you just have to remember. Okay, so if the arm is up, it's either flexed or abducted. So aren't you glad you didn't have to model for these pictures? So we should all stand up and I should have you do that. So adduction, okay, medially. So we're coming back in closer to the midline of the body. Okay, flexion, even better. Okay, flexion, so shoulders flex, elbow flexion, hip flexion. Knee flexion is interesting because it's posterior. Okay, so reducing the angle at a joint is another way to think of it. Okay, extension. Okay, so which arm of this young lady is extended?
Left.
Right or left? Yeah, it'd be the left. So this is actually hyper extended. So we can extend, but then if we go back behind the body, that's extra. So that's hyper extension. So shoulder can hyperextend. Can the wrist? Yeah, if you put your hand flat on the table, you can, that's hyperextension. Can the hip? Yeah, you can go back. So there's a few joints where we can have safe hyperextension. We obviously don't want hyperextension at the knee joint. So, but some joints we have safe hyperextension. Circumduction. So as noted here, it's sometimes called circumflexion. So we are inscribing a circle or a cone with our fingertips. So those old Western movies where they're on the cattle drive. So anything to help you remember these terms. Diagonal abduction. Okay, what was our analogy? Lawnmower, right? Or maybe you have a better one. Diagonal adduction is throwing, or you could say serving a volleyball. Adduction, diagonal adduction. External rotation. So which of her arms is externally rotated? That looks like it takes a lot of balance. Yeah, the left. So she's, what would the right one be then?
Internally?
Yeah, so internal versus external rotation. The hip can also do that. And so the right hip would be externally rotated in this case. Okay, so we referred to this just a little bit, but for the foot, you have two joints below the true ankle joint where you can turn the foot out. That's called eversion or sometimes pronation of the foot. So in running circles, sometimes you might hear about this concept of overpronating. So that would be putting more stress kind of on the inside of your foot. So maybe you get shoes that have a better arch support to prevent overpronating. Inversion, that would be turning the sole of the foot in. Okay, so now sitting there, why don't you do just a quick test? Tell me which way you have more range of motion, with eversion or inversion. Which way can you go further? Which one has more range of motion?
Inversion.
Inversion, yeah. So about 90% of ankle sprains are inversion type sprains. So if you're rolling your foot in, so the sole of the foot is facing in, that's going to be stressing ligaments on the lateral side of the ankle. This has a lot to do with the structure of the tibia and fibula, but I don't want to get to that yet. So dorsal flexion, plantar flexion, everybody good with these terms? Know what they mean? Okay. So radial ulnar joints, everybody good with pronation and supination? Okay. Scapular movements, so let's talk about these for just a bit. Scapula, so what joint are we talking about? Big discussion, first part of class. It's not a true diarthrodial joint. The connection of the scapula to the back of the rib cage, what do we call that joint? Scapulothoracic. So that's where most of the movement takes place. When we talk about scapulothoracic, or just, you could just think of it as movement of the scapula, movement of the shoulder blades. So depression, basically in the anatomical position, you're already in depression. So the only place to go from depression is where? Yeah, elevation. So elevation and depression. So that would be frontal plane movement, elevation and depression. Protraction and retraction. So everybody put your hands out like this, okay? So I want you to, at this point, I want you to spread the scapula as far as you can possibly go. Think of the scapula gliding around the rib cage like that. Okay, so that's protraction, okay? Sometimes called scapular abduction. Scapular abduction. I like protraction, that's easier to remember. Retraction, so now we're back here, and then we can squeeze those scapula back in together. So that's retraction or scapular adduction. So we get really pronounced amounts of these either at the very beginning of a movement or the very end of a movement. Kind of depends. So it kind of sets the stage, or it's more of a finishing type action that happens at the end of a movement for the shoulder. Okay, rotation downward and rotation upward. So if you think about the scapula, if my hand represents the scapula, when you push a weight overhead, the scapula swings up like this. So if you're doing an overhead press, as you press the weight up, if my hand represents what the scapula does, the scapula kind of swings up like this. So that would be rotation upward. Now, if you have more of like a wide grip lat pull down or a wide grip pull up, okay, as you pull down and as you come down to finish that action, again, if my hand represents the scapula, it's going to be coming in like this. So in this position, it's going to be up, and then as you come down to this position, it's going to be swinging down like this. So we call that rotation downward. Okay, horizontal abduction and abduction. Everybody good with those terms? What plane would these be? Around the body is transverse. Okay, so what plane would this be? Out to the side. Frontal. What plane would this be? Forwards, backwards.
Sagittal.
So then this would be
Transverse.
transverse. Okay, scaption. This is included in your text, and I'm glad it was. This is a unique action of the shoulder joint. Okay, so notice the angle 30 to 45 degrees. So it's not the frontal plane. It's not, what plane would this be? Sagittal. It's kind of more in the diagonal plane right here. So you're coming out to the side right here. So research has shown that this particular action, if you add just kind of that little angle to it versus forwards or to the side, that you engage that serratus anterior a little more. And that's very important because that upwardly rotates the scapula. So this is really good to help prevent impingement, rotator cuff impingement. Okay, so spine movements, lateral flexion. So you're in this position, lateral flexion is like this. Okay, so lateral flexion, I'm out to the side. So how do I get back? It's called reduction. So lateral flexion or side bending, and then reduction is back to the anatomical position. Okay, palmar flexion, dorsal flexion. Okay, so this refers to the wrist. So palmar flexion would be like this. So then dorsal flexion is like this. So Corey, you do both of these, don't you? This and this, yeah. So which way are you generally stronger? Yeah, exactly. So if you do isolated wrist joint actions, you're a whole lot stronger with the palmar flexion than you are turning it over with the dorsal flexion. So dorsal flexion is kind of a misnomer. I wonder how that all got started, because dorsal flexion is actually what? What are you actually doing? You're not flexing, you're extending, right? You're hyperextending, but it's kind of the same thing with plantar flexion at the ankle. What are you actually doing at the ankle?
Extending.
You're extending it, right? But we call it plantar flexion. So I'm not sure how the history of all that started, but okay, wrist and hand. So radial flexion or radial deviation, ulnar flexion, ulnar deviation. So I want you to look at your hand. Okay, I want you to bring it in towards your body, and then I want you to bring it away from your body. Which way can you get more range of motion?
Inside.
Yeah, so we get more range of motion with ulnar flexion than we do with radial flexion. Okay, opposition, reposition. What joint was that again? The first what? It was it is the sellar or saddle joint of the body. What specifically was it? The first carpometacarpal joint. Just one example of a sellar or saddle. So opposition and then reposition. Okay, so I think what I'd like to do at this point, this is the very end of the chapter, and it would be better if everyone was like fresh when we talk about osteokinematics. So what I'd like to do is just kind of change course. Let's go ahead and do that small group activity now. So what you have are two activities. The first one, you're given the joint and you're asked to list the joint type. So for example, for the wrist, what would you say? 2 is, remember?
Biplanar.
Biplanar, or which of the 6 diarthrodial type joints? There's only one that has 2, that's condyloid, right? So you're going to list condyloid, and then you're going to put check marks by the planes. So we're considering this from the anatomical position. So for the wrist, you can go forwards and backwards, that would be sagittal. You can go side to side, which would be frontal. So you'd put a check in the sagittal and frontal box. So let's do another one. So elbow, what's the joint type? Hinge. Okay, if hinge is easier, if ginglymus is easier, either one of those terms is acceptable. Which plane from the anatomical position?
Sagittal.
Sagittal is right. So you just put a check in the sagittal box. Okay, so that's part 1. Part 2 is activity 17 right here. So what you're going to do is look at the joint action. So cervical rotation, so that would be this. Okay, so what plane would that be?
Transverse.
Transverse or horizontal. Okay, whichever you can remember is fine. Transverse or horizontal. What's the axis for the transverse plane? Vertical, or sometimes longitudinal is another word. So just those 2 activities. Okay, so I want you to work together. Activity number 15 and activity number 17. Okay, so I encourage you to use your textbook. I did bring an extra textbook. If anyone would like to borrow it, or you can just use the internet. How's it going?
So just 15 and 17, not 16?
Oh, this isn't too stressful. Let's go about 10 minutes. I won't have you turn this in today, so you can take it home with you, but I'd like you to be here about 10 more minutes and get as much done as you can. Oh, here's my book. You like it? Okay. First hand up. You got it.
Okay, that was my question.
Yes.
How come depression and elevation are in the frontal?
Frontal plane, you're looking at something like a picture, is the view. Whereas a sagittal would be looking at someone from the side. Frontal plane would be looking at someone from the front or the back. So, it's not moving side to side, yes, but it is, you're able to see it from a front or a poster. You can't see the actual scapular thoracic. That's a
Medium one.
I think if you like adopt an abductor, scapula,
You want to try the axis too?
just check the plane for that first activity. Yeah, whichever, from the anatomical position, yeah, just sagittal, and then the other would be plane. So shoulder, for the shoulder joint, you're gonna have to check all three.
The sternoclavicular, it's lining, not saddle, right?
Yes.
Okay, because saddle.
Say the shoulders and fallen.
Now would be another one of those frontal planes.
They can only see moved.
Yeah, so it'll probably be all the planes and our